Thank you very much. Really great to be here today at the Tata. It's thanks to the organizers for putting this together and the opportunity to speak. Really looking forward to a great 2 days of working, listening, learning, and meeting a lot of new friends. I'm going to just kick things off, talk about the importance of clinical research in advancing patient outcomes. And I'm going to focus on clinical trials. This is my hometown of Kingston, Ontario. It's a beautiful town right on one of the Great Lakes, Lake Ontario. And this is sunrise over the lake. That's our city hall there. So there's no doubt that clinical research has had a huge impact on patient outcomes. This is an example from medical oncology and an example from metastatic disease. When I was training, the median survival for people with advanced melanoma was less than a year, and we had single agent chemotherapy. And now with chemotherapy and with doublet immunotherapy, people with metastatic melanoma have a median survival of 6 years in this clinical trial with nivolumab and ipilimumab. Huge advance and huge importance for patients and improving patient outcomes. But it's a very costly drug, and not all of the trials that we do have this type of outcome. Joey Del Paggio, former trainee of mine and a protege of Dr. Booth, who's in the front line, did an excellent trial looking at the evolution of randomized clinical trials. Dr. Booth has been doing this now for a couple of decades and looking at randomized clinical trials in oncology over a couple of decades. And this latest update of this trial was a retrospective cohort study of systemic therapy in 298 randomized clinical trials in breast, colorectal, and non-small cell lung cancer, published in 7 major journals between 2010 and 2020. And the findings from the current period were compared to data from randomized clinical trials in the previous 2 papers, 1995 to 2004 and 2005 to 2009. What this study showed is that 90% of randomized controlled trials are now funded by industry. Previously, in the previous iterations of this, it was 57 and 78%. So a huge influx of industry sponsorship, and that's brought about some great things. Industry sponsored and supported the trials that we've seen with advanced melanoma. But it really has also driven the question, because there's been an increasing use of surrogate endpoints, and Dr. Booth is going to be talking about that in his talk. And although we've seen incredible outcomes with things like pembrolizumab for metastatic melanoma, the median improvement in overall survival in these trials was only 3 months. So very modest benefits and an increasing influence of industry. And they concluded in this paper that to demonstrate that new cancer treatments are high value, the oncology community needs to consider the extent to which study endpoints and target effect size provide meaningful benefit to patients. So if we're going to improve patient outcomes, we not only need to be doing good clinical research and good randomized clinical trials, but they have to be focused on outcomes and questions that are important to patients. I'm fortunate to have been involved with a cooperative oncology trial group called the Canadian Cancer Trials Group. It is actually based in Kingston, but it's a national Canadian group. And it's an academic-led research group. So it's run by academic oncologists from across Canada. Dr. Tanek has been involved, Dr. Booth, and I've been privileged to be involved with this group. It's an outstanding group, and their mission is to support the development and execution of trials that matter. So trials of treatments that are based on the best science and with the potential for the greatest impact on patient outcomes. There's more than 80 institutions that are involved. And from right across Canada, and there's a comprehensive support in terms of biostatistics, trial organization, all centered in Kingston, but running trials that are national and international, and a lot of international collaborations. And unlike the industry-driven trials, this is a group that can focus on meaningful trials of outcomes and questions that are important for patients. So this trial it's called CX5, CCTG CX5, is a gynecologic cancer intergroup study, but it's led by the Canadian Cancer Trials Group. And it's a randomized phase 3 trial comparing radical hysterectomy and pelvic node dissection versus simple hysterectomy and pelvic node dissections in patients with low risk early stage cervical cancer. And, industry is not going to sponsor or initiate a trial like this. This took academics to think of the idea, international collaborators to design the study endpoints, and international collaborators from around the world. And this is led from Canada, but there are international collaborators from Korea, the UK, Austria, China. And they tried to have more input from countries in Latin America. They had some difficulties, but they're trying to reach out to countries with low and middle income countries as well. But these types of trials aren't going to be done by industry. I'm fortunate to chair one of the new rectal cancer trials, and we're looking at a fairly simple and cheap therapy, including short course radiotherapy and FOLFOX, comparing that to short course radiotherapy and FOLFIRINOX, to see if we can increase the rates of complete clinical response in rectal cancer and increase the rates of non-operative management. This is really important to patients. Patients coming in to the clinic with rectal cancer who've had a complete clinical response to neoadjuvant therapy want an option for non-operative management, and these trials aren't going to be done by industry. So I think developing cooperative groups like this is really important. I believe, and Dr. Pramesh is going to be talking about collaborative networks and research as well. Speaking of Dr. Pramesh, this paper on priorities for cancer research in low and middle income countries, a global perspective, is really important to read, because I think that the other thing about trials is we not only be asking the right questions, but we need to be sure we're doing them in the right populations, because by 2030, 3/4 of all cancer tests will occur in low middle income countries. And most of the increase in global cancer burden in the next 50 years will also be in low middle income countries. A 400% increase in low income countries, 168% increase in middle income countries, and compared to 53% in high income countries. Another paper from Dr. Booth's group, but international collaborators, including Dr. Sullivan in the front row, Bashal, our colleague from Queens, and J. Connor Wells, the lead author, looked at 694 randomized clinical trials from 2014 to 2017, and only 8% were led by low and middle income countries. But importantly, randomized clinical trials from low and middle income countries were the one that were more likely to identify effective therapies and have a larger effect size than those from high income countries. So asking questions that had really meaningful impact in improving outcomes for patients, but only 8% of them were from low and middle income countries. The paper goes on to talk about research gaps, and less than 1/3 of registered clinical trials for the 3 highest burden cancers, cervix, breast, and lung, are recruited patients from low middle income countries in 2010 to 17. And many countries in sub-Saharan Africa recorded no clinical trials activity. And this means that there's really a lack of context-specific, high-quality evidence on which to make the best treatment decisions for patients, to create clinical guidelines, and to allocate resources wisely. And it's going to widen the global disparities unless we can address this in cancer care by concentrating knowledge generation, application, and infrastructure within high-income countries. So it's really important that all countries should be able to participate in cancer research relevant to their own populations, and the trial recruitment must be representative across age, sex, ethnicity, geography, and socioeconomic status if clinical trials and clinical research are going to continue to improve outcomes for patients. In terms of strengthening research capacity, there are individual efforts for individuals to learn the skills that are important to develop and lead clinical trials. The Collaboration for Research Methods and Development in Oncology, the CREDO network, is a leading one led by Dr. Ranganathan and Dr. Pramesh, and many of the faculty here have been involved with that. I think organizational elements are critical, and we're very fortunate in Canada to have the Canadian Cancer Trials Group. And that type of level of infrastructure support is key. clinicians, biostatisticians, trial and study management teams, and also a robust ethics and regulatory framework. I think in terms of strengthening research capacity, we need to do more to improve cancer research networks. And I'm not going to talk a lot about this because I know Parmesh is going to be talking about it, but I think there are potentially good examples of north-south collaborations, but they have to, stakeholders have to work in a fair and cooperative manner, in a non-colonial manner. And also some excellent examples of south-south collaboration, including National Cancer Grid of India, Aortic, Argo, and R4HC MENA. I think this is going to require strong support from government or other societies. In Canada, the Canadian Cancer Trials Group is strongly supported by the Canadian Cancer Society. And also, we're fortunate to just get a $20 million grant from the federal government. I think it's really important for us to advocate for strong government support and other research organizations and funding bodies to promote a culture of research and integrate science and technology strategy at a political level. High-income countries can help and play a role, but that's not sustainable. And really, governments in low and middle-income countries need to increase funding for health research in general and cancer research. And there's a really good economic argument for that in terms of improving outcomes. These funding opportunities have to be disseminated widely. So really looking forward to a lot of the talks today, and a lot of are really focused on these themes. I think Dr. Parmesh's paper setting out the priorities for global cancer research is important to produce high quality, locally relevant data that can guide high value care. But I think there's one other key element to enable research to improve patient outcomes, and that means that the people caring for patients with cancer, clinicians, need to be able to use that research wisely. And we're proud at Queen's Global Oncology Program to create a masterclass in critical appraisal so that clinicians and trainees who are going to be taking care of patients with cancer are able to interpret the evidence and to use it wisely and carefully discriminate the meaningful outcomes that are going to help their patients. And many of the contributors, Dr. Tanik is here, Dr. Giawali, Dr. Ranganathan led the first session on randomized clinical trials. This is available online for any of you who want to do it. This is linked also with live events where we have small group sessions to help improve critical appraisal techniques. And Dr. Sengar was a great help with that and led one of these live sessions. We also have really good contributions from faculty from across South Asia and also from Africa. We are in the process of developing new modules on biostatistics and enabling research. So clinical research is absolutely critical in advancing patient outcomes. We need to maintain and build the infrastructure for trials that will contribute to improving the most meaningful outcomes for patients. And we have to do that for patients across the globe. And I hope this is a good setup for the rest of the meeting, and looking forward to learning more and meeting you as the day goes on. Thank you very much.